now we have two classes of patients, okay? Those with blockers
Yep.
and those without.
Yep.
And we have one agent, a new agent, that can reduce the rate of bleeding in both groups, right? Who do you switch?
I think for the inhibitor patients, I think it's a straightforward discussion. I mean, obviously there's a debate about whether you should get rid of an inhibitor. And like I said before, we're looking at whether you can use Hemlibra with our current ITI regimens or immune tolerance. But it gives patients an option. That's what's great. I mean, if they don't feel like they can do the immune tolerance or it's just not possible for them in their life in that time, then this is a great alternative to reduce their chance of bleeding. It's going to be more challenging in the non-inhibitor patients because, as you know, there are plenty of patients that are doing extremely well on factor replacement. They've learned to deal with this, and it's sort of that old saying, if it ain't broke, don't fix it. And so some of those patients certainly will not switch. And so, they might not use that phrase in New York, but they use it down in Georgia.
Oh, they use it in New York. But the thing that you're not changing is intrusive.
Sure.
I mean, yes, they're used to it, right?
Yep.
But it's still every few days, IV. Yeah. This is a lot. I mean,
once a week or once every 2 weeks sub-Q. But I think it's great that the families have an option. We inform them and say there's more data, obviously, on factor VIII. We have data on that for decades. And some families feel comfortable, like, you have to think about it. If their grandfather was on factor, or their brother's on factor, and they might feel connected to that community. So it becomes more complicated than this therapy is better than the other.
Yeah, and you put somebody on Emicizumab, and they may think that they're quote unquote cured.
Yeah, invincible. Yeah.
But how do you work with a patient who now wants to be more physically active?
Yeah.
And to what degree? And do you provide bleeding doses? And
Sure.
so it brings up a few other.
There's a few unknowns in there, so that's the only reason some people might tread lightly.
You're not going to advise somebody on Emicizumab to go play in the NFL.
No, definitely not. So yes.
Not even as a punter.
Yeah, we don't advise most of our children not to play football in general. So yes, but again, we don't want them to say, oh, now I can do all those sports I never could do. And so we have a little less information about sports, but I can tell you on the trial, we had kids that had inhibitors that had never been to a park before, which I thought was just devastating. With children, can you imagine? They just couldn't deal with restricting them at a park. And then they were coming and they were feeling better, and then they just kind of let their kids run loose. I saw a kid last week who's finishing up on the trial. He's got 6 siblings, and they play flag football with each other. Mom says ever since he started, before he would bleed and he'd have to sit and watch, and now he's participating and he feels great about it. And he doesn't think anything of it, but obviously he felt good enough to participate now.
Now, we talked about Haven 1, Haven 2. You alluded to Haven 3.
Yes.
So is that the trial you're talking about now?
Yeah, so that's the trial in which they looked at the ability to work in non-inhibitor patients. And so...
so that expanded inhibitor patients, clearly an indication.
Yes, in Haven 1 and 2,
Now let's try it in the rest.
Yeah, let's try it. We feel like it works just as well in non-inhibitor patients, and they demonstrated there was a tremendous benefit for that. We had teenagers involved in that study, and obviously a lot of adults as well. And they switched an overlap with their factor VIII concentrate, and then they switched over to this product, and there was a dramatic reduction in bleeding events. There was in the 80 to 90% reduction rate. And so you don't see many clinical trials where you see that kind of dramatic reduction. And again, they showed patients that were on factor VIII prophylaxis. Some of them, we measured them for a period of time, and then they went in the study and we measured them the same way, and they had a significant reduction in their bleeding even with that. So yeah, so it was a very good design to answer the questions we wanted to answer. So these have been published in various settings and presented at trials.
Okay, so I come back to this. Let's put money aside, just for a moment. I know everybody's got money issues. And I understand also people trust 8, and they've had 8 in the family for a long time. But is that, I keep coming back to commercials, this ain't your father's Oldsmobile.
Yeah, exactly.
We've moved on.
It's not your father's hemophilia.
It's not my dad's hemophilia anymore. Why wouldn't you just start everybody on this new molecule where there's almost no downside other than it costs money, but everything costs money.
Yeah.
Well, Lacey brought up a good point earlier just about kind of osteoporosis in hemophilia patients. And so if you totally eliminate the need for factor VIII, what does that do to someone's body?
Yeah.
And to be honest, we don't know. And so for patients who start when they're really young, especially a patient who doesn't have an inhibitor. For a lifetime of no factor VIII, what does that look like?
Lacey, was the implication of your statement that factor VIII was contributing to the osteoporosis?
No, it could be doing the opposite. It could be the lack of factor VIII is helping the bones and preventing osteoporosis. That's why the lack of factor VIII might lead to osteoporosis.
So we know that patients on blood thinners have the same issue. So is it because they don't make enough clot? So it might have nothing to do with the factor VIII at all. We don't know that. And so we worry, does this mimic all the other factor VIII functions, right?
Exactly.
We're all focused on the clotting stuff. Factor VIII does other things outside of the clotting cascade.
Just when I thought it was safe to put down my textbook.
Yes, it
what
definitely-
other things?
Well, like bone mineral density, we think it does play a role in that.
Factor
and
VIII.
Factor VIII, and so, and probably factor IX as well. And we don't know if is it because the kids are not participating and doing exercise like their normal counterparts, or is it something intrinsic in the lack of factor VIII? Because we're replacing it, but we're not replacing it at the same rate. And so these are all things that we're going to learn, and they're a little bit more of a minor issue, obviously, than bleeding. But you take a baby that's just born, and the family has no family history, or they have a family history, and everybody in their family is in factor VIII. And so these conversations are about hour-long conversations because you're explaining the whole history of hemophilia and what's the current therapies. And there's still unknowns, right? We put them on emicizumab, there's probably going to develop inhibitors to factor VIII because when they bleed, they have to get factor VIII. Does it matter? Maybe it doesn't matter. We might delay their inhibitor formation until they're adults. Is that okay? And so there's just a lot of potential unknowns. I think these are all good things, and it just tells us that we need to continue to do research in this area. So we're not done. We don't need to shut down the pharmacies and say, well, it's simple now, they just do this drug. No, we don't need this. We still need those experts to take care of them.
If you look at big things first, right, life and death.
Sure.
If you've got a drug here which will keep people alive with less risk, that's a good drug, right? Now, we'll worry about bone mineral density, right? And we're not going to know about that for maybe a generation. And giving them factor VIII, not necessarily a bad thing from that perspective, but it is a bad thing for lots of other reasons.